We're here today to talk about healthcare. We're joined by three healthcare industry leaders in Wisconsin, also joined by Mark O'Connell of the Wisconsin Counties Association. Jim, you're chairman of Wood Communications and Strategic Counsel to Competitive Wisconsin and the BeBold Council.
Mark, as Mark has suggested, Competitive Wisconsin's goal is to improve quality of life and competitiveness in the state of Wisconsin on behalf of its citizens and institutions. We've been doing that since 1981 in one fashion or another. Most recently, starting in about 2010-11, we started something called the BeBold initiatives. And the BeBold initiatives are a process in which we engage business leaders, folks from the academic community, the expert community, the governmental community, et cetera, to focus on large issues confronting the state of Wisconsin. This is our third BeBold initiative that we're here talking about today. And the assignment this time was to try to identify two large employment clusters that were really contributing to Wisconsin's economy and to its quality of life. And we did that by going to the UW-Madison, UW system and asking for some research help in terms of identifying two clusters that had sustained positive job growth and had capacity for further job growth in the state of Wisconsin. Wisconsin Economic Development Corporation also helped with some of that research as we went forward. And we identified two major employment clusters. One is the healthcare community with us today, and the other, as you know, Steve, is food manufacturing.
One number that stresses the importance of healthcare is 400,000 plus Wisconsin residents work in the healthcare industry?
Yes, at least 400,000 depending upon how you count it. And so they're a major segment of Wisconsin's total employment piece. And I actually have some charts we can share with you if you'd like to take a look at those.
I'd love it. Thank you.
Wisconsin's healthcare employment cluster is a critical piece of the state's economy, which is why Competitive Wisconsin selected it as one of the two clusters we were going to focus on in the BeBoldIII exercise. There are basically four reasons for that selection. The first is that it's a major player in the state's economy, and let me put some numbers on that. Our adjusted workforce statewide in 2016 was approximately 3.1 million people. More than 400,000 of those Wisconsin workers, nearly 1 in 8, was employed in healthcare, and they and their employers comprised an economic engine that generated 8% of Wisconsin's gross domestic product in 2015. The second factor that's important from our point of view is that the healthcare cluster employment sector has been growing steadily since 1990. So that this is not a late blooming phenomenon, it is a consistent phenomenon over time. And as a result, Wisconsin now ranks in the top 30 states from an employment point of view in ambulatory care, hospital and nursing and residential home care facilities. The third thing that caught our attention when we were looking at it is that employment in the healthcare industry tends to be a stable phenomenon. And so when you compare turnover rates between healthcare employees and other forms of employment, it's very, very stable, and that's a critical piece of the equation. All of that said, that is that it's a major economic engine in the state, the fact that it's been growing for a long period of time, and the fact that it's a stable factor in our state, all critical. There are, however, two concerns that I think are worth noticing. One is that as the population in our state has aged and grown larger, we have a workforce shortage in the state in terms of our capacity to provide care. And the second area of concern is that when we just look at the age of the workforce and probable retirement issues, in 2015, nearly 1 in every 4 hospital and ambulatory care employees was 55 or older, suggesting that these two sectors will need to replace 60,000 workers within the next 15 years.
So Jim, those are the charts and the numbers, but there is a specific subject for this program. Can you talk about that specific subject?
You bet. I mean, again, just to remind everybody, the purpose of the BeBold exercise was to identify things that were working for people in each of these clusters in the state of Wisconsin, things that were not working for them, and opportunities that might lie down the road. And so essentially, both sectors identified as their number one issue workforce, different kinds of workforce issues, but workforce. And that's what we're going to be talking about this morning, is what kind of workforce issues are adversely affecting the healthcare community in the state of Wisconsin, what kind of workforce opportunities exist for us to move forward and produce better outcomes, and some other ideas that, as you know, we had conversations with folks, and I'll let you introduce that.
Well, we did have some fascinating conversations with actual professionals out there working in healthcare in Wisconsin. This is a great time to listen to them talk about their issues.
This is the culmination of a very long process in which providers and healthcare people concerned about healthcare in the state of Wisconsin have come together, done a lot of research, had a lot of conversations. And one of the major conclusions that came out of that was that, like everybody else in the state, we have workforce shortages, but perhaps unlike everybody else in the state, our workforce shortages produce a broader kind of risk for the state. It's both a public health risk, but it's also an economic risk in terms of how it affects our workforce and our capacity to keep workers and to recruit new workers into the state. And I'd like to start there. We have people from the academic community, we have people from the provider community and the professional community. And I'd ask you to let's start with a conversation about how you see that shortage playing out in your particular arena, and how it touches your community. So, and Bob, let me start with you, okay?
So in our community, we certainly are seeing a lot of healthcare shortages from our workforce, and what it really means to us is our ability to provide care for the residents, the patients that come to us. Having a shortage in your emergency department can be critical. It can mean life and death to the people that depend on our organization to be there, to be ready for them 24 hours a day, 7 days a week, being able to provide that care. On a less emergent perspective, within the last couple of years, we experienced a shortage of surgical technicians from an allied healthcare workforce perspective. That limits our ability to provide surgical services in our organization. It limits the ability of our physician surgeons to practice what they've been trained to do. And then finally, the most significant workforce shortage that we're seeing is with our certified nursing assistants, specifically in our skilled nursing facility. That shortage of nursing assistants has forced us to admit and take care of fewer residents in our nursing home environment, which is so difficult to do and tell a lifelong resident of our community that we don't have the staff to provide care for them when they need us the most.
Right. Lisa and Pam, you're both in the educational arena trying to grapple with at least a piece of this problem. And perhaps you could give your thoughts. Pam, let's start with you.
Well, sure. Thank you for this opportunity. The workforce issues in regards to how we're going to grapple with this has, as you had previously pointed out, is the economic issues. And I can speak from personal experience, having been a chief executive officer. I had to close down a personal care agency and also a home care agency for exactly part of these reasons. And, it's home health aides, it's personal care workers, and it's registered nurses, and it's having physicians even in the area. And when that happens, the economic issues is a dissolution, a decimation that happens not only within the agency and the organization, but it happens broad spectrum, because then you lose the number of people that you have who are contributing to the economy, who are contributing to those local businesses, who are contributing to the school districts. So every single one of those things has a continued revolving, decimating aspect that comes through into the community.
Let's help Lisa.
On the physician side, I think we see a couple of issues. One is the length of time for training, is because we have such a long training time, between 7 and 10 years for many physicians. We really have to act quickly, because you can't just crank out more as you sometimes can do in other specialties. The other issue, I think, aside from the economics, or in addition to the economics, is the patient safety issue. If patients have to travel, and particularly with things like obstetrics or emergency care, we're really compromising safety for our communities. The economic issues obviously are very important, but as an educator, we really try to encourage our students to think about where they practice as part of the economic vehicle of the community, as well as part of the safety net.
Interesting. And Bud, you're obviously dealing with the physician side of this issue as you look at it. Want to give us your perspective on the situation?
Well, maybe one comment on the economic side that made drive the point home is that we all know that that Amazon is looking for a place for its next large headquarters, and my bet is Austin, Texas. And the reason my bet is Austin, Texas, is that I've recruited physicians to Texas, and I've recruited them to Wisconsin. And when I recruited them to Texas, I got 10 applications for every specialist that I was looking for. When I recruited in Wisconsin, I was lucky if I got one. Now, part of that might be the climate. Part of it might be other things. But in Texas, it's just a good place to practice. And we don't have that in Wisconsin for whatever reason. So we have to look at our training programs, what we offer our physicians, our retention, how we set up our practices, what we demand of our physicians from documentation, how we retain our physicians as well. When a company comes, I think they look at transportation, airports, road systems, but I think they also look at who's going to take care of the people that are going to be working for them. Absolutely. We have a good occupational medicine, work comp environment here, and we have a good malpractice. Hopefully, they'll reestablish the non-economic damages cap. I know we're not here to talk about that, but for some reason we're having some difficulty, recruiting physicians. We've done a lot in establishing more graduate education positions, which is real positive, but we still have some definite issues we have to deal with.
Okay. And Ann, you've done a lot of work in this area. What can you share with us here?
Sure. I think if I think about the employer perspective, one of the things that's different about healthcare careers and training is that the employers provide their future employees the training site. And so if we have a lot of unfilled positions, one of the bottlenecks we see is that we can't accept as many CNA students as we'd like or CMA students as we'd like. The bottleneck from a physician's side is we need those residency slots because we know in Wisconsin we're a rural state in a lot of ways, and if we can train physicians in a rural setting, they're much more likely to stay, and that might get at the recruitment dilemma that we're seeing right now.
And I think all of this resonates with what came out of came into the BeBoldIII healthcare report in terms of saying this is, again, not just a serious issue, this is beyond serious because it threatens public health and it threatens the economic well-being of the state. The step from there was to say, well, if it's that serious, what do we do that's different about it? And the first piece of the equation was, is there a way to put together some sort of consortium, whatever word you want, that would enable us to reach out and tap the strengths and bring them together in a fashion that gave us more flexibility as we focus that set of resources. And George, your Wisconsin Council on Medical Education and Workforce is clearly a central model for how that perhaps happens. So maybe you could weigh in at this point in time and talk about, as we got to that point and started talking about how would we proceed if we were going to do that, what kinds of things you see in the immediate offing?
I think we've done a lot of very good work in starting more programs in training physicians as well as nurses and other allied health professionals. It tends to be more on a local level. It's more organic in that way. So I think that has a benefit in itself. I think as we do this more and more and see increasing numbers of folks making their way into the training and clinical setting for training, we're seeing increasing numbers of conflicting priorities. We're seeing folks who may not find a placement. We're seeing organizations that may not find the people that they need to train. And so there's a need for more of a broader perspective on that, I guess, from at least my way of thinking. And maybe more of a regional or a statewide way of dealing with this, a way of managing it, and looking at where the sites are available, who's looking for those sites from a training perspective, both from the educational organizations as well as from the individual students. As I said, the organic aspect of this has been very good. Individual organizations will make their priorities and set their priorities accordingly. But when we begin to look at the need for a more coordinating effort, I think that's something that's a kind of a next step in the process. The grants that were made available to organizations to start new graduate medical education programs over the past 3 or 4 years have been very successful. And now, the way that they were structured was to have a grant be made to an organization that could show that they could build a new program from scratch in many cases, which requires such things as preceptors and other faculty and other resources. That has produced very good results, but the point I'm making is that at some point that reaches its limit. The number of preceptors or other available faculty is limited by a number of factors, such as the ability to take time away from your work, as well as other training and pieces of the infrastructure that need to be in place. So I think we need a broader view of this. We need a different way of looking at it and funding it than we have up to this point. As well as those programs have done, we're reaching a point, I think, where we need to look at it in a more comprehensive way.
So if the public understands the crisis to be a numerical shortage, that has to be the top priority, as opposed to just saying, I need better GME access or I need whatever. Somewhere in the plan, don't we have to talk about, this is what we can do in the next year, this is what we can do in the next 2 years, this is what we can do, so that we are in a position to say, not only are we asking you to support this program, not only are we asking you to put money into it, but here's what the investment return looks like over a defined period of time. Is that legitimate, and do you think the healthcare community will respond positively to that?
I think it's a very legitimate point. Readdressing some of the things that have been talked about. We really need to work with the state to provide that funding, so we have the educators providing that clinical training in the classroom. We need to work with the employers, the hospitals and the clinics and the nursing homes to make sure that we have the clinical rotation sites to train our nurses and our CNAs and our physicians. It's a multifaceted point. If we don't have the instructors in the schools, we're not going to get the young men and women the classroom education that they need. But if we don't have hospitals and clinics providing that practicum, that training, that clinical training that can only be done in that setting, we're missing out. We have to work with the state to make sure that there are resources available for both our educational institutions as well as our healthcare organizations to work together on solving the issue.
I'd like you to all think about a person who you would like to have understand this workforce issue, and think about the single most important thing you think they should know, and then give it to us in 30 seconds, okay? And I'll let anybody go first who wants to go first.
Well, I'll go first. I'd like Senator Johnson to understand, what we're up against, from a workforce issue, and would explain it in the way I've, tried to explain it here, is that we got retiring physicians, we got physicians that are underproductive on what they really ought to be doing, and that if we don't change that, I don't think we're going to be able to solve the problem and the economic benefit of having additional physicians in a community and more productive physicians.
Okay, Lisa?
It's hard to pick a single person because I think they're. Yeah, I think that more flexibility. I think one of the reasons we're seeing early retirement is because of the lack of flexibility. So I think that both at the HRSA level, at the state level, at the local level, we need to encourage physicians who may retire because of one reason or another to consider coming back in as preceptors or clinical teachers. We need the same with nursing and other fields. We really are not only short of practicing, but we're short of the people who will create that new population of physicians and other healthcare providers. We've already created 2 new medical school campuses in the last 2 years, but we're struggling to find preceptors and clinical staff because they can do many other things.
I guess I'll add to that, and I'd say I'd like to reach out to my healthcare executives, my colleagues, and reinforce the point that we are part of the solution. Right now we're experiencing the shortages, but we are part of the solution. That solution being working with the different programs, working with the medical schools, working with the colleges and technical programs to make sure that we're providing those educational training sites in our organizations. It does add a little bit of work. It doesn't happen overnight, but the rewards are there.
I'd like to say that I'd like to give a premise basically to all of the policymakers because they're very critical in how we're going to solve this issue. And I think that the commonalities amongst all of us is it doesn't matter exactly which discipline it is that we all are needed. And as population health changes and as those data points change, we're going to see that health is going to become much more broader. We didn't spend a lot of time talking about home health, but there's more of the aspect of health occurring out in our home and our population settings. And not to negate the value of acute care, but we're going to be changing a whole lot in how we're going to address health in the future. So I'd like them all to be involved.
Okay, George?
And I think in addition to looking at the issues of today, I would encourage us to help folks take a longer-term view. Because as we indicated, about 20 years from now or so, we'll have a severe shortage of physicians and other clinicians based upon the demographics of the state. We'll be much older in terms of the average population. We'll have fewer number of the population in the workforce age category from 18 to 64 than we have today. So that will be, if it's a crisis today, it'll be much more of a crisis in the future, and that long-term view I think is important as well.
All right. I want to put a plug in for to our policymakers for team-based care and technology. I think team-based care is the secret sauce in terms of helping providers work longer because they're supported by other licensed individuals working to the top of their licensure and their expertise. I think we all rely a lot on technology, and so I want to put a plug in for broadband access. We need to fund good access everywhere, because if we can do things on our smartphone, like, I don't know, go to the movies or whatever, we should be able to support that in healthcare also.
Let's give our healthcare professionals a chance to introduce themselves. Sir.
I'm George Quinn, Executive Director, Wisconsin Council on Medical Education and Workforce. It's a private foundation dedicated to improving Wisconsin's healthcare workforce.
Good morning. Tim Size, Executive Director of the Rural Wisconsin Health Cooperative. I've been around 40 years. It's a collaborative of also 40 rural local systems, focusing on shared services and advocacy on behalf of rural Wisconsin.
Good morning, Eric Borgening, President and CEO of the Wisconsin Hospital Association. We've been around since 1920 and represent all of the state's hospitals and health systems, and are a very focused advocacy organization when it comes to all things healthcare related.
Mark, you're a vice chair of Competitive Wisconsin. Your organization cares a great deal of how Wisconsin's economy can grow and prosper. So why are you a part of this dialogue?
Well, Competitive Wisconsin is an entity that it's comprised of private businesses, associations, organizations interested in making Wisconsin the most competitive state we can possibly be. What that means is that we need to look at the various private sector, sectors of our economy and see where we have advantages, where we can improve, where we can expand upon or take advantage of the marketplace as it sits today. In addition, we want to look to the future. What does the future look like, and how might Wisconsin be best positioned to be in the best possible position for future success?
Thank you. Jim, you're a leader of Competitive Wisconsin, in addition to your private firm, and a member of the BeBold Council. Set the table. Why is this such an important dialogue?
Well, as you can see, Steve, I mean, these are real people talking about real issues, and essentially, to get the conversation going, they identified in this long process in the research 3 different specific issues. One is a net shortage of workers in the state of Wisconsin, and they've made a recommendation in that case that their cluster, their peers, and others support a private sector-driven initiative focused on workforce recruitment in terms of the state of Wisconsin. The second issue, which is obviously more pressing from their vantage point, is that they see the shortage of doctors and nurses in this state as a crisis, and they see it that as both a threat to public health and to the economic well-being of the state, and think we have to deal with that. And then the third issue is the question of location of resources and facilities in terms of whether that impacts quality and accessibility to healthcare. So those are the issues kind of on the table.
Well, okay, let's start with number 1. Can we defend the question for panelists? Can we defend the decision to call the nursing and a physician shortage economic, number one, and a public health crisis that needs immediate attention. And we're throwing this open to all the panelists. Eric?
Sure, I'll start. I think if you're not viewing the situation with the healthcare workforce as a crisis or an impending crisis, you're just not paying attention. And the data is, there's plenty of data out there that tells this story. You know, we survey our members, our member leaders once a year to see what's literally keeping them up at night. That's the question. And the responses in December went in this order. Number 3 was government reimbursement for healthcare programs. Number 2 was the stability of the insurance market. And number 1 was workforce. It is the top of mind issue as they look 30 years down the road, as they look just to 12 years down the road, when the population age 65 is expected to double by 2030. So it's a not really a long-term problem, but it's also a short-term challenge, and they're both driven by demand. So you have that aging population, we have a nursing workforce that's retiring, that will be retiring in a significant number over between now and 2030. And probably the best example of an immediate concern and challenges in the area of behavioral health and the workforce we have in psychiatry and other behavioral health professionals. It is significant, and it comes at a time when demand, especially when you think of the opioid crisis that we're facing in this state today, the demand for behavioral health, AOTA professionals is higher than it's ever been, and it's creating those really acute and serious shortages that we're seeing today, not in 2030, today.
Eric, thank you. Tim, and then?
Well, from a rural perspective, shortages are not new to us. It's just the nature of the beast. It's a little harder to recruit to a smaller community than it is into the suburbs or many urban communities. So we've been on this workforce issue for a long time, and we appreciate the work many people in our state have done already. I think what we're all saying is we have to really up our game given the retirements that we're facing. I would agree totally with Eric on the whole mental health issue. We've spent the last 3 or 4 years creating a telehealth network. A lot of people say, well, that's how you solve the problem. Well, the reality is it doesn't create practitioners. It makes it a little easier for them to get around and not have the windshield time. You don't need to recruit as many into rural areas. But our biggest problem, there's just no one to hire. What happens, I think I'll stop there.
Well, okay, I want to come back to that last statement. No, there's no one to hire, but George.
Playing off of both Eric's and Tim's comments, we take a look at the future when we're working with workforce shortage questions, because it takes an extended period of time to train physicians and nurses, about 10, 15, 20 years. So it's important to look at what the demand for those services, for those practitioners is likely to be in that time frame. 20 years from now, the overall Wisconsin population is projected to increase about 12%. But because of the much higher proportion of seniors in that population, the demand for healthcare services is projected to increase by 23%, or double the population. Now, we're not working on the same levels of production of those clinicians as the 23% that's going to be required there. So there will be a gap unless we make a significant change about what we do and how we do it starting today.
Mark, before we bore down a little bit, there's 2 sentences in the BeBold recommendations I want to ask you about. And it is, we are not talking about creating jobs. We are talking about filling jobs and creating taxpayers. Now, you're here to talk about the overall economic picture, so please.
Well, this is the healthcare industry. I think Eric said it best. If you don't view this as a crisis now, you're not paying attention, because we have a crisis today, whether it's a crisis of access, which we have in our rural communities, or a crisis of workforce, where we know we have to train people to populate this sector of our society to serve a population that we know is exploding. I mean, George talks about how the post-65 population is going to grow by, well, maybe perhaps double, but that's assuming we have no medical advances. Well, with the medical profession, we're going to have medical advances. We're going to more than double. What that means is that if you're a young person today, let me put it in terms of, employment. I've said for the past few years now, if you're a young person today and you want to determine where you're going to work, what your wages are going to be, what your benefit package is going to be, go into the healthcare arena. The demand is incredible. It's incredible today, and it's even more so in the future.
Well, and that's why I want to come back to Tim. You said there's no one to hire, or whatever. Why? Because it's a rural area? Because they're not trained? Because there are better jobs elsewhere?
There's a balance here. I mean, obviously a lot of people love working in rural Wisconsin. But if you're short a doctor, you're short a doctor. If it takes 9 months to recruit the right nurse rather than 3 months, all that has impact on people either delaying their care or having to leave their community for the care. I'd like to pick up on what Mark said in terms of the economics of this. That's unique for rural. When rural businesses, individuals pay their taxes or healthcare premiums, those dollars don't sit in a bucket in rural. They go to a bank somewhere in Minneapolis or New York or Madison. They only come back into that community to help that community's economy if those healthcare providers are there to provide the services and be paid for them. So rural Wisconsin, rural health in rural Wisconsin is a big part of our economy. Even with our small co-op of 40 middle to smaller hospitals, we're $3 to $4 billion worth of rural Wisconsin.
Let me, if I could also put this in some perspective. When we talk about it being an economic issue, the Pew Foundation, based on University of Virginia population research, has indicated that they are projecting a 5.5% decline in Wisconsin's 25 to 54-year-old workforce between 2015 and 2040.
It's overall workforce. That's not just healthcare.
It's not just healthcare.
Thanks, Jim.
But it's 25 to 54. If you take that's 118,000 plus people. If you take that number times Wisconsin's per capita income, you're losing $5.4 to $5.5 billion a year in income. Do a 5% tax on that, and you're out $276 million. Okay, you do a property tax factor on it, you're out close between those two factors, state and local taxes, in excess of $400 million a year. That's an economic impact that affects the cost of doing business in those rural counties and in those urban counties. It means there isn't money for schools. It means there isn't money for roads. Hard to recruit the workers you need. So these two issues, workforce shortage, not people you can hire, not people who are paying taxes because they got jobs, that impacts our economy in the state of Wisconsin.
Eric, are hospitals also having trouble right now finding people to fill these very critical jobs?
Yeah, I think for sure. That's been the case for a few years. It kind of ebbs and flows in terms of where the demand is greatest or we measure it by vacancies. And vacancies are actual open positions that are being recruited for. So that's a growing problem. It's a reflection, where those vacancies are is kind of a reflection of how healthcare is changing. A lot of vacancies in advanced practice nursing and other professions that are part of teams of care, which is how we're increasingly delivering care. But back to this other point, I think it's really, healthcare is unique. I mean, it's no doubt, I mean, we are in a sort of a competitive dynamic with other industries in what seems to be sort of a finite or not really growing, in fact, shrinking workforce pool. And so what's different about healthcare is demand for healthcare is not necessarily driven by something economic. Demand for healthcare is driven, at least in the next few years, by the aging of a population. Yet we have a pool for our workforce that's not keeping pace. So I think that it's really a couple things. We have to, as healthcare, we have to take a broader interest in just the overall economic health of our state and growing that workforce, growing people moving to Wisconsin. I think that's something that healthcare is an important part of. And second of all, our public policy approaches to this have to be very smart, very targeted, and I'm sure we'll get into some of those discussions later, but we have to target public policy and tailor it to where the need is. So we talk about rural areas. If we're going to talk about how do we use public policy to solve these problems, we've got to create programs like matching grant programs, which we'll probably talk about later, that are focused on rural areas and appealing to kids, adults from those areas. How do we appeal to them to go into healthcare because they're most likely to stay in those areas if they come from those areas?
Well, we've used the word crisis. Does the public Do the patients understand that there is a crisis as we begin to get into perception and how to change some of these issues? Is the public aware?
Go ahead, George.
I think the public is becoming more aware, and once they understand all of the factors behind what we're talking about, especially we're talking about economic impact, if you're focusing on rural areas in particular, having health care in a particular community makes a big difference when it comes to businesses and industries making decisions whether or not to locate there. In addition to the economic impact, the fact that the folks make a very good income and they also spend money in their own communities, it's an infrastructure issue in a way, because those businesses and industries will take a look at what's available in that community, roads, banks, bridges, and so forth. But healthcare is a big part of that infrastructure question.
Tim, you wanted to say?
Yeah, I mean, this is a unique issue for rural because while our state is aging, rural Wisconsin, particularly the northern tier of counties, are already advanced in age. We wouldn't have a problem if, I see our panel, most of our panels are of retirement age, but obviously have not retired, they are here, and we've made choices to continue to stay in the workforce. Unfortunately, we're not typical. What is causing the problems that Eric said is in large measure our aging population. My generation are retiring, we're retiring from work. What makes it unique for healthcare is, as my generation retires from work, unfortunately, we are entering the stage of being very active consumers of healthcare. And that's what makes it different than from welding or teachers, whatever, because most healthcare in our country that's used and paid for are folks in their 60s, 70s, 80s. So, I mean, it's really the demographic distribution of the demand for care that's creating this crisis. So I would say most of our state leaders, most of our communities really don't understand that we're entering a crisis. We have spot shortages, and they're very serious when you're that spot. The big problem is, as George said, 5-10 years from now.
Mark, your organization represents all 72 counties. This is a critical issue for rural counties north of Highway 10, isn't it?
Yes.
And that's I realize I just picked a highway. You could pick 29, but
You could pick 29, you could pick Highway 19, quite frankly.
it's a big issue for northern Wisconsin counties.
It's a big issue everywhere, and I want to pick up on something that Tim said. I mean, is the public aware that this is a crisis? Well, we have programs like this. We have very smart people talking about the future of healthcare and how we're going to, I guess, put us in a possible position for success. But when this program ends, or when you're done reading the article in the newspaper, is it still a crisis? Well, it's a crisis when an individual has to travel 3 hours to get care. It's a crisis when a child is ill but cannot get the care unless they go to a major metropolitan area. It's a crisis when I don't have the broadband necessary for me to even get telemedicine so I can have some identification of what challenge I'm facing as a family. Then it's a crisis, and then it's real, and then it's personal. We need to engage in activities, and the BeBold report has recommendations that put us in a position where we don't have to have those kinds of challenges. And that's really what this report is about.
Right.
Experts identifying those recommendations.
And again, if I could piggyback on all of this conversation, just to put this again in some perspective, the Wisconsin Department of Administration's population projections, okay, from now to the year 2040 indicate that the only major change in population blocks by age in this state will take place in the 65 and older population. And they specifically are projecting that there will be an 82% increase in the Wisconsin population 65 and up between now and 2040. So if you think about everything that people are saying, this is March 19th, 2018. We are 22 years from 2040. You hear experts from the healthcare community telling you that we have a workforce shortage issue now, that it's directly related to our capacity to find doctors and nurses and accessibility, et cetera. And you have a projection that says roughly 4,000 additional patients a year are coming into that system every year for the next 22 years. If that's not a crisis, I don't know what is. I think what's interesting, and I'd be interested in our folks talking about this a little bit, is that when we talked about this workforce shortage in terms of doctors and nurses, and all of these organizations have done studies over the last few years on the shortage, so there's a lot of really good data out there. But one of the things that struck us as we had the conversation was, unlike other workforce shortages, there are people lined up who want to be nurses, and there are people lined up who want to be doctors. And so the challenge here wasn't finding the people as much as it was figuring out how to get the people trained, educated, and placed. And I wonder if you could talk about that a little bit.
Well, I'd kick it off. I would compliment both of the state's medical schools. They've both taken resources and expanded the number of medical graduates. Our choke point for physicians is the shortage of residencies, places where physicians go after graduation to get the additional training. That's urban shortages, that's rural shortages. For nursing, it's a little bit different. I think we've had not as many spots in our nursing schools. Our schools of nursing across the state have responded. They're looking at the same data we are. The choke point, I think, for schools of nursing is the single oldest cohort in the health sector is nursing school faculty. We are ill prepared for the wave of retirements that's going to hit us. So like the schools have presently expanded, they could actually fall back in the next 5-10 years as they're not able to replace the faculty they're in the process of losing.
I think it's a really important point. And it speaks to the importance of making sure that our educational institutions are able to respond to the demand. I look, for example, at the UW-Stevens Point, I think it was, that just recently announced that they were making some changes in some of the majors that they're offering, and those are not uncontroversial, but they're sort of moving towards allocating resources to where the needs are greatest and where the demands are greatest for Wisconsin today and going forward in order to grow our economy and our workforce. And I think that's critical that our educational institutions continue to do that, especially when it comes to healthcare and reallocating existing dollars and making healthcare a priority investment within the UW system. I think that's really, really important that they wisely use the dollars they have. And Tim brought up another important point as an example. I think it's critical that we take ownership of this issue, this problem, this crisis. And we do it in a partnership with the state and with public policymakers. Physicians are a great example of that. We've known for some time that we're facing a pretty significant shortage in primary care physicians, and you can define that in a lot of different ways. And we used the research that was done by the Wisconsin Hospital Association and followed up by the Wisconsin Council on Medical Education and Workforce to really inform our public policy work in this area. So we know, for example, from that research, if you take a Wisconsin kid, they go to Wisconsin Medical School, and they do their residency in Wisconsin, there's an 86% chance that they will practice in Wisconsin. So you take the research like that and the equation that creates, and you use public policy to try and attack each component of that equation to come up with solutions. And Tim alluded to, or I think, or Jim or Tim alluded. Tim said, I think it was Tim that gave credit to the medical schools for expanding that capacity. MCW in particular has used some state assistance to expand medical school capacity in Green Bay and Wausau and is accepting predominantly kids from Wisconsin. And then we've created a $6.5 million matching grant program to expand graduate medical education, those residencies that are the third component of that equation. So it's not the answer, it's definitely using public policy to make a good step towards a solution of Wisconsin trying to take responsibility and accountability for its own problems.
2 follow-up questions, rubber meets the road questions. What are the barriers to young adults, 18 to 25, becoming trained as the next generation of nurses and physicians? Question number 1. Question number 2, do we lose some of our trained physicians and nurses to other states?
Yeah, I think a couple of ways to answer that question, one of which has already been addressed by both Tim and Eric when it comes to physicians. I think when you're talking about nurses, it's a very similar kind of issue, which is that half of the training and education and training takes place in the classroom, roughly half of it. The other half takes place in a clinical setting, seeing patients. Residencies are all about physicians seeing patients, but nurses need to have the same training. And so what needs to happen there is similar to what's happening with the buildup of residency programs, is an increase in the infrastructure for nurse training and physician assistant training very much in the same way. Public policy can be brought to bear in that regard too. There's a new grant program that's coming on board right now that will provide grants, matching grants to hospitals and health systems that agree to start brand new nurse education programs in the clinical setting. So that's one of the barriers that exists right now, is lack of adequate infrastructure for that training.
So do we have enough young adults 18 through 25 who want to be physicians and nurses but are running into the barriers that you just outlined, George?
I think there are many more than we can meet the needs for. We have folks who basically end up practicing out of state or having their education in other states, and they may not come back. So to the extent we can provide that training here, we have a much better chance of retaining them back in Wisconsin.
I would just add to what George said. I think George and I and Eric, we've been involved with this conversation for a fair number of years, and I know historically, at least with physicians, Wisconsin's been a net importer of physicians for some of the reasons Eric spoke about. We have to understand we're not the only state aging, and we have to be at least as competitive as other states around us up their game and do a better job of keeping their graduates in their state.
So let me piggyback, if I can, on what all three of you have just said. The recommendation that came out of the long process and the data and the research was that in order to do what Eric is suggesting the healthcare community needs to do, which is to be a partner in public policy, to own this issue, to move in, was that if the problem are choke points like access to faculty or access to residency or practicum opportunities, then we needed to come together in a different dynamic, okay? And so the recommendation in the report is that a consortium, in this case they've recommended the Wisconsin Council on Medical Education and Workforce, would work with public policy people, with patients, with others in the state, business leaders, et cetera, to take a look at the fundamental question, and instead of saying we're short faculty in Eau Claire, or we're short faculty here, or there are retirements going on there, they would say, what is it we need to do here? And based upon the data, I think the projection on nurses was a shortage of 27,000 nurses over the next 15 to 18 years. And we're already short, as I understand it, by a couple of thousand nurses. So if you're trying to address that quickly, how do you go about doing that, okay? And I think the report talks about there's been a lot of research done, probably need to do some more research, but you got to bring people together to focus on, there's a timeline here, the clock is ticking, we need to move this forward, what is it going to look like? And then the second question was, well, if you're going to do that, what is the revenue stream? Where's the money come from to pay for getting this job done? Okay? Because the money that's out there right now is being consumed doing the work that you folks are already talking about. And the key there in the recommendation in the report was the recognition that if these jobs don't get filled, there's no tax revenue. There's no property tax revenue, there's no sales tax, there's no income tax to the state. And so the premise in the report is if you can fill a job and that job stays filled and that person stays in the state for a period of time, that there is potentially a revenue stream from the tax revenue that gets paid as a result of that job being filled. And if you can figure out how to monetize that, you now have something that enables you to move forward with changes and investment in the process. So if you could talk about that a little bit in terms of, I think that would be helpful.
pick up the last point in terms of how do we monetize, as you said, Jim, but I've served on the state's bond authority that helps basically conduit issuer for bonds that helps educational facilities, hospitals, clinics get the cash to build a building that's here for 30 years. So we're making those investments, and we have a way of doing that. We have a way of getting cash today to get the resources we need for tomorrow. We really don't have a good mechanism for that when it comes to the professionals to work in those buildings. So part of what I liked in the Competitive Wisconsin Be Bold report, without being overly specific, but at least was saying, look, where do we get the money to really do an incremental step in the number of people we're either recruiting into our state or training to work in healthcare? And I don't know what the right answer is, but I think for me, it's been useful to think of it as a bond or at least investment by the public sector into today's workforce so that we have that workforce in the future. The same way we're building facilities today that will be around for 20 and 30 years.
George, the recommendations of Be Bold would really cause a sea change and greatly empower your organization. Just to read from the recommendations, the council would convene and serve as the base for a larger consortium of medical professionals, academics, and employers tasked with cutting through red tape, identifying new synergies, finding ways to get the people needed, trained, and certified. Wouldn't that put your organization on high-profile steroids? And what changes would it envision for your council?
Well, I think, as you indicated, we've been doing that very same job for the last 5 or 6 years.
At this level, but these recommendations would take you up to the stratosphere.
I understand.
Excuse me.
I understand. But that provides, I think, the platform, the foundation on which we can build what you're talking about.
So your organization's ready to do this, to step up?
Well, I think there are a number of things that would need to be added. We would need to add, for example, while we have on our council pretty much every stakeholder in Wisconsin's healthcare workforce, we currently do not have, for example, representation from employers outside of healthcare. It's an entirely healthcare-oriented group at this point. So we would need to have the other stakeholders that are affected by that. I think that's step number one. But the process that we've used over the past 5-10 years or so would I think be essentially the same in that it's a forum and a platform for discussing and better understanding issues surrounding workforce, and then ways to tease out, if you will, potential public policy initiatives.
Eric, the Hospital Association would certainly be a major stakeholder in this debate over the consortium. What are your thoughts on it and how it could work? Is this the number one recommendation that the Hospital Association support, or one of many?
Well, I think the concept of a consortium is an interesting one, in particular if it serves a purpose of convening research and study and information that helps drive the discussion. I think there's a lot to deal with in workforce in healthcare, and so I think we have to be cautious about bundling all that up in this report and handing it over to one organization. I think that's something that on paper might make some sense, but the progress we've been making in the state so far has been based upon a lot of good research and data and analytics that's come together, people coming to the same table to talk about that, and looking at public policy solutions and acting on them, putting lead on the target, if you want to put it that way, actually identifying problems and solutions and moving forward with those. So I think those come from a lot of different places. A consortium, however that's defined, can help sort of bring some of that information and research together. It's a big undertaking to go steps beyond that, but I think it's something that's worth looking at. But at the same time, the need is great enough that we have to continue moving forward with some of the solutions that we've already put on the table.
Tim?
Yeah, I actually would agree with both Eric and Steve. I'm sorry, Eric and George. I think it's important to remember our consortium is a way to, I think, make for a more efficient sharing of perspectives of information around the state. It by no means replaces the hard work that all of us in our individual organizations need to be doing. There's more than enough work for everyone here. I think WCMU is well placed to be the convener, because that's essentially what we've been doing at WCMU. I serve on their board, and as on their council, it's kind of work that we've been doing for a long time already, and we just need to take it up to a higher level. But at the same time, Eric with his organization, me with the co-op, and all the other actors, we need to get more increasingly serious about this as well.
Mark, nuts and bolts politics question. Of all 5 of us, you spend the most time in the Capitol with elected officials. Is there an awareness, with all the issues they're dealing with, of the critical workforce shortage in Wisconsin's healthcare systems?
Well, I think there's definitely an awareness of a workforce shortage. Is there an awareness of the specific industries? I think by some, certainly. And I think there's no question there is a caring about the workforce shortage and what it is we do about that. The trouble is the workforce shortage, while it is definitely a today issue, it is absolutely a tomorrow issue. So it's hard to have conversations that are 10, 20 years into the future. Although our legislators, I think, desire that, there are so many today challenges that there's the mental energy necessary to think about 10, 20, 50-year challenges. It's difficult when we have so many today challenges.
Jim, would the consortium idea require changes in Wisconsin laws and statutes to empower Georgia's council?
Again, I think there are a couple of issues here, and I'd love to hear the conversation. So the answer to your question is yes.
Yes.
Okay, is I think that they relate to the question of whether or not you're going to have a revenue stream that you can dedicate to resolving something you have identified as a crisis. Okay, and so I think in this day and age with tax bases eroding, unless you can address that question, people will not take your proposal seriously. I think that's a fact of life. The second piece I would put on the table is, I want to go to what Mark just said. I think it's very hard to persuade people that you have a crisis when you keep using 5 and 10 and 15-year time frames in your discussion, okay? That doesn't sound like a crisis. It sounds like a thought process. It's like intellectual push-ups, okay? A crisis is something that's touching me now. And you all spoke with passion about the opioid crisis, about access to facilities, about the need to recruit people and keep them here in the state of Wisconsin.
3-hour drives to care.
Yeah, that's here now. And then you say, but it's going to take 10 years or 15 years to train these nurses. People don't understand that. I mean, somehow that conversation is going to have to get, I think, a bit more focused.
Well, I want to, Mark, I want to come back as the one who spends most time in the Capitol. Here's a specific recommendation. The first 4 years of state taxes paid by newly employed physicians and nurses to a fund would be dedicated to funding the recruitment, education, training, and certification of physicians and nurses. Specific recommendation to be bold. With all the demands on GPR funding, do you think this idea could be sold?
I think it could be sold, yes.
You do?
Because I think there are legislators, I would say 132 legislators and a governor that care deeply, deeply about the future success of this state. And when we step back and look at the demographic challenges we are facing and look at the individual sectors in our private sector economy which are necessary for our future success, this jumps out, it leaps off the page as one of them. So when we look at what is necessary to create that successful environment, I think people will look at this and say, this is a unique one, this is different, but it's necessary.
It is also not a request for GPR financing.
Thank you for the correction.
Yes, it is. I mean, I think
Outside the GPR revenue stream.
that is absolutely
outside
essential.
the state checkbook.
It is.
Thanks,
The
Jim,
premise
for the
is
correction.
that there is a pool of money out there that becomes available when you fill those jobs. If those jobs don't get filled, the money isn't there. But if you fill the jobs, there is money there. And so the question is whether it's bonding or it's some other public-private investment opportunity. And these things are happening around the country. Okay?
Yeah, I agree with what you said, Jim, about short-term, long-term, but I know it's coincidental. I have a grandson, he's just turned 6. 2 or 3 years ago, when he was still in daycare or wherever, I was putting money into a college fund. He's not going to need that college fund for another 12, 13 years. I think so partially it's communication. I think a lot of parents Okay, if we frame this in terms of even their own families and how they plan for the future, I'm not quite as pessimistic. I take your point, but I have to believe our legislature can.
The problem I've got is you've all produced reports that say it's not 15 years in the future. The shortage is over the next 10 years.
And I think the problem is we've largely been talking in an echo chamber with ourselves, and that's why I've been very pleased to see Competitive Wisconsin, the counties associations, and others start to share this problem, because we can't solve this problem just we healthcare folks. We need you to be with us on that.
Yeah, the point you just made I think is really important, and I'll say a few other things. I think it's critical that other industries share this concern. The Counties Association, the Wisconsin Manufacturers and Commerce, other industry associations need to understand how truly imperative the healthcare workforce is going forward, in addition to their own needs. Back to the issue of 10 years, 15 years down the road, and the echo chamber, I think that's all true, but the fact is I'm somewhat optimistic about some of the steps that the legislature has taken to address this issue, to hear our concerns and make investments that may not pay off in a budget cycle, a 2-year legislative cycle. I point to the graduate medical education grant that was created in 2013, and funding was added to it in this last state budget. The Rural Wisconsin Initiative, which was created to, which $1 million in it to help expand clinical training capacity for nurses and allied health professions. And that's, I think, a first step. Point being is we've used the success of the graduate medical education, where we can document and show the number of new residents that are in this state, that we hope a vast majority of which will stay in this state as a result of that program. So that's important. It's not like nothing's being done. I think the legislature and the governor are hearing some of these concerns among a number of competing voices on workforce, and we're coming to the table with ideas and solutions. As far as funding, there's certainly precedent all across the state budget for earmarking dollars, and for earmarking sort of specific dollars for specific purposes. Transportation is certainly a very good example of that. So I think the precedent is there to earmark the dollars, but we would want to make sure that those dollars are actually used for initiatives, proposals that can deliver results, kind of like graduate medical education funding has done. And second of all, that those dollars are added. They're not supplanting existing state money, because that's always the risk when you earmark funds or you have a sort of a dedicated revenue stream that you're adding to existing dollars. You got to make sure that they're actually added, not supplanting.
Eric, as someone who also spends a great deal of time in the Capitol with our elected officials, this idea of dedicating the 4 years of state taxes paid by newly employed physicians and nurses to a fund, not GPR, thank you, Jim. Is that a viable option as you interact with lawmakers and elected officials?
I think what's viable is the notion of dedicating a revenue stream, earmarking industry-specific dollars. We do it with the gas tax, we do it with the registration fee. We even do it with some GPR dedicated to transportation. I think that the precedent is certainly there. I think we'd have to make the case for that. These are not dollars that exist now in the state budget, so it's really not something that's coming out. I think that's a positive. But it also depends on what we will do with those dollars. Like I've said earlier, I think what we've been able to do is demonstrate success, at least initial success, with some of the uses of GPR for a healthcare workforce, and we need to be able to do that, and I think we can.
Well, pardon me for interrupting you, and I would encourage everybody to read the report, because essentially that's the role of the consortium, is to go and not rush off into wildly, but to pay attention to what does work and doesn't work. We are now running out of time on this program. What I would like to do is give each of you guys another minute to any last closing thoughts that you want to just, something that you've been burning to say. If you don't have something, that's fine. But
one final question as we close this session is, if we don't seriously address the workforce crisis, it gets worse. And what are your major concerns if we don't address it 5, 6, 7, 8 years out?
I can
Tim.
start and be uncharacteristically brief. I really think you'll start to see the hollowing out of rural healthcare. You'll start seeing most healthcare being in our larger cities, our mid-sized cities, because the workforce shortages, if we don't address them, will most adversely affect rural. And you'll see clinics and hospitals in rural areas having to downsize their footprint there. And that means more and more people traveling to get care, which means delayed care. It means more expensive care. So this is profoundly important to our rural parts of the state.
I'd agree with that. Tim put it very well. I really couldn't add much to it other than we'll see a sort of a depleting of access to care, or a sort of concentrating of access to care. We have a member now who, because of their inability to attract and retain CNAs, is having to turn residents away or admissions away from their local nursing home. So that's a real sort of tangible example of what we're talking about. Now those folks have to go somewhere else because they don't have the capacity in that nursing home in their community. So it's a real challenge. I think what it boils down to is access to care at a time when we know demand for care will be increasing exponentially.
Does that amount, that example you just used, does that amount to rationing of care?
I don't know if I'd use that term. I would say sending people further distances for care.
Thank you. And George?
Well, let me end on an optimistic note, if I could, and suggest that Wisconsin has a good history of identifying problems and working on them in a very collaborative way. Examples have been pointed out previously about how we identified the graduate medical education shortage issue, brought that to the legislature, and the legislature acted upon that, and now we have, right now I think we have a total of 100 new GME positions in the state that we didn't have before, graduating about 20 new physicians a year. So I suggest that while those dire predictions could possibly happen, I think it's less likely given our history.
And Mark, put on your 72 county hat. If we don't get it right, if we don't begin to address it?
Well, I think we'll have access to care questions. We will have availability and waiting for care questions. We will have smaller, or in some cases, elimination of some major employers in our counties. It'll have a dramatic negative impact on our economy. We will still have to have $10 to run the county, which means that it will be spread out to other folks, and it is only bad things happen if we don't address this now.
Any wrap up on this segment? Yep.
Good health care is one of the most important components of quality of life. And what we're discovering as we look around trying to deal with workforce recruitment and retention issues is the questions related to housing, taxes, infrastructure, education are all important. But quality of life is the deal breaker. And when you get to quality of life, there is nothing more important than good health. So I think the dire projections or concerns, at least, are justified. I hope that George is right, but I think we don't have the luxury of waiting to see. If we don't, we need to deal with this issue, and we need to deal with it now.
Fascinating discussion about a very critical issue, workforce in our healthcare systems. Gentlemen, thank you all very much.
Thank you.
Thank you.